So this evening, we are here to discuss COVID-19 in the brain. And of course, speaking from one hotspot to another, we all know we're in the midst of the worst pandemic in over a century. And we're quickly closing in on almost 9.5 million cases worldwide, 2.5 million cases in this country. And tragically, over 120,000 people have already died in the United States. So the reason we're here to discuss COVID-19 in the brain is that while initially COVID-19 was thought to be primarily a disease of the lungs, we now know that COVID-19 poses a serious threat to the entire nervous system, including the brain, the spinal cord, the peripheral nerves, and the muscle. COVID-19 impacts the brain in at least a third of people who have this coronavirus, and some estimates are much higher. And we're very concerned not only about what the acute effects of this disease are on the brain, but the long-term effects in millions of people who have been infected by this virus, as we've seen from the influenza pandemic from 1918, where the long-term effects were only realized years later. So tonight we're very fortunate because two of the most renowned neurologists and neuroscientists in the country, who I'm privileged to work with and who we're privileged to have on our board, will walk us through the current understanding regarding the effects of COVID-19 on the brain, what we know now, what we don't know that needs urgent research as well. So our first speaker tonight is Dr. Frances Jensen. Dr. Jensen is a professor of neurology and the chair of neurology at the Perelman School of Medicine at the University of Pennsylvania. She's also the co-director of the University of Pennsylvania's Translational Neuroscience Center. And her research focuses on mechanisms of epilepsy and stroke and the mechanistic interaction of epilepsy with other disorders such as autism and dementia, with specific emphasis on bringing about new therapies for clinical trial development. She's formerly the president of the American Epilepsy Society, and she's the current president-elect of the American Neurological Association. She's received many awards, including the Pioneer Award for her research from the NIH, and she serves on the scientific advisory panel at the NIH for the Brain Initiative. And her research focus, I think, really embodies ABF's focus, which is to understand common mechanisms underlying multiple diseases. And I think she has her finger squarely on the pulse of COVID-19 and the brain. And so I'm delighted to be able to introduce Frances to you. And Frances, welcome and thank you for being here.
All right, great. It's a real pleasure to be here, and I hope that you guys all learn something. Where Jim Grotta, who you will be introduced next from Texas, is going to be tag teaming with me around different aspects of the problem with coronavirus and the nervous system. And this is another one of these stories where we can build on the foundation. We have a lot of unknowns, as David mentioned, but we can build on the foundations we have for basic neuroscience and translational and clinical neuroscience and treatment trials throughout the nervous system in order to figure out what can we use that we already know to attack the problems of coronavirus. So I'm just gonna briefly remind you all of sort of what we're dealing with and how we think coronavirus gets into the nervous system and the array of different symptoms that we know clinically. And then we can kind of have some Q&A after Jim's spoken about some of the more specific aspects in some areas, a little bit about like what might be known and what kind of questions could be asked and what sort of research is going on. So these coronaviruses have been around since the mid-60s, and as you know, there are multiple different types of coronaviruses. Many of them, there are about 7 or 8, and most of them are cause the common cold, but there are 3 or 4 that are more serious. And we've seen coronaviruses before with SARS, as you recall, MERS, and now we have COVID-19. It is another one of the coronaviruses. And as you know, COVID-19 is referred to as SARS-CoV-2, as opposed to the original SARS, which is SARS-CoV-1. Interestingly, all 3 of the more serious forms of coronavirus, SARS, MERS, and COVID, came from bats. SARS came from a horseshoe bat through, I think, a civet, and MERS came through an African bat through camels, and COVID has come through bats, we believe, through pangolins probably. And they all initially got into the airway and epithelium of the lungs and can cause a very severe respiratory disease. We've learned a lot about what COVID and some of these other diseases, these other coronaviruses do beyond the lungs. And that's what we want to talk to you about, specifically beyond the lungs and into the nervous system. A lot of these viruses hitch onto receptors in our bodies, and one of them is called ACE2, which you might have heard of because they're ACE2 inhibitors that treat people with cardiovascular disorders, and it's kind of provides an entry point for the coronavirus to hook in to infect a wide range of human cells in the lungs, the bone marrow, spleen, skin, heart, reproductive organs, and brain, specifically different parts of the brain. And interestingly, in the inner olfactory epithelium of the nose, which I'm going to explain why that's relevant now. When you think about COVID-19, while possibly even as many as half of infected persons are asymptomatic, those that are symptomatic, we can look at how common different types of symptoms are. About 90% of people have fever, about 50% have some kind of respiratory problem, a cough. About up to 70% lose taste and smell, which is a neurological problem. And then about a third of people have some kind of a mixture of either headache, which is a mild neurological symptom, or other things that are more severe, a brain infection, stroke, lack of oxygen to the brain because of the lung disease. We know that it can get into our brains through the blood. It can get in through having come through, pass into the lungs, into the brain, through the blood. We also know that it can create, go directly into the brain that way. We also know that it can create a lot of trouble in the rest of your body and set off inflammation all over your body, which then can actually just the inflammatory cells invade the brain. That's another way we can have trouble in our nervous systems from COVID. And then the final way is actually going directly into the brain through the nose, because actually the nose, the olfactory epithelium, which is the receptors that help you smell, are in the very back of your sinuses, and they actually go back up into your brain, into something called the olfactory bulb in the front of your brain, so that the smell signals can get passed along. So we now know a lot, and this has actually just been discovered in the last 4 or 5 months since Wuhan happened, right? All these different ways that we can see our brains and nervous systems get affected. We know that actually there's a range of, we now can start to separate what things can happen because of direct viral invasion, either through your blood or through the nose, potentially. And we also know what can be what we call indirect diseases caused in the nervous system by COVID. For instance, all that inflammation I was talking about, the inflammatory signaling coming in and attacking the brain in kind of an autoimmune way, or just simply because of bad lung disease, the loss of oxygen, not getting enough getting enough oxygen up to the brain will of course cause brain injury, can sometimes cause seizures. And then of course, there's which Jim will talk a little bit more about, there's a tendency for people with COVID-19 to have their blood clot more, and that hypercoagulable state, in addition to the inflammation, may be the source of some of the strokes, the block of blood flow to the brain that can be seen in people at different ages. So we know a lot now about the array of types of issues. So I thought I'd just tell you about one that I think is quite an interesting story, because people are noticing this new, that some people can just have lack of smell. And in fact, somebody at, actually at my institution, a scientist named Jay Gottfried, is working on, he's a smell expert, and he is working out why do you lose a sense of smell? And it turns out it's very likely that the virus comes in and attacks these cells in the back of your nose and turns them off so you can't smell anymore. And he is trying to do a study, for instance, trying to understand, is that somebody who's just going to have a mild course? Is that actually predicting of a mild course of COVID, because it often can happen very early in the disease? Or is it something that's going to portend very bad symptoms? So he's like trying to study people now to see if, people who lose smell, are they a special group that might actually be protected in some way or might be more vulnerable? So these are the kinds of studies that are now finally going on. Some of the other areas where we're looking at the inflammatory systemic inflammation, we sometimes call it a cytokine storm, meaning these cytokines, these inflammatory molecules that can be set off when you have really bad lung inflammation, they go all over your body. They don't just stay in your lung. And that can go in and really wreak havoc in your brain very broadly and cause people to have seizures, stuporous, go into coma, because of what is almost like an autoimmune attack on the brain. And we know a lot from prior research about autoimmune attacks on the brain. And we're hoping that can come in other forms, like you may have heard that story of like the term brain on fire. There's a book called Brain on Fire. And this is it was written about scientists that actually were the first to find that you can develop antibodies to your own brain cells and cause inflammation. But now that we know how it happens, we actually have treatments for a disease that never used to be able to be treatable. So of course, there's great interest in the neurological and the neuroscience community to see if some of these brain injuries that are happening from COVID might actually we could adapt those other treatments. Remember the cure one, cure many, to that the brain inflammation that's due to COVID. I'll just say there's a whole story about stroke, and I'm going to leave that to Jim. And one of the things that David mentioned that is another thing that's just emerging as a concern is you might recover from COVID, but is it over? And certainly other disease types, other viral syndromes can give you delayed diseases. For instance, there's a disease called Guillain-Barré, which some of you might have heard, where people can become paralyzed a few weeks after a relatively innocent viral infection. And we know a lot about the mechanism of that. We're waiting. There have been cases of that have been reported after COVID, because there's an attack on the nerves going into the spinal cord by these inflammatory signals. And then we are also worried about diseases that might be even more brain focused, such as Parkinson's, which we saw with the post-encephalitic Parkinson's that was seen back with the influenza of 1918. That takes many, many years forward, but we've got to monitor people, and we have modern imaging techniques to be able to look for those things. So we might be able to find those kind of answers out much sooner than waiting 40 years for somebody to develop Parkinson's in later life, like they did with in the pandemic of the last century. So I think I've just stopped there. Basically, the overall message is many parts of the nervous system, from the brain to the spinal cord to the peripheral nerves, can be affected because of either this indirect effect of all the inflammation or a direct invasion of the virus. And there's much to be studied, but I assure you that the research that's going on can rest on the foundation of other great research that has been done in other areas of neuroscience and medicine. So I'll stop there and hand it over.
Thank you, Frances. And as Frances mentioned, after Jim speaks, we will be happy to take any and all questions related to COVID-19's effect on the brain, or just COVID-19 questions in general. So our next speaker is Dr. Jim Grotta. Jim I don't think I've ever told him this before, but I learned a lot of my stroke neurology from Jim by running to his courses at the American Academy of Neurology, because he's such a superb teacher. But he is the director of stroke research at the Clinical Institute for Research and Innovation at Memorial Hermann, Texas Medical Center. And he's the director of the Mobile Stroke Unit Consortium. Dr. Grotta launched the nation's first mobile stroke unit in 2014, which won funding from the American Heart Association and the National Patient-Centered Outcome Research Institute to conduct the only randomized trial to evaluate the cost-effectiveness of this novel approach to stroke treatment. And it was Jim's pioneering work in developing that mobile stroke unit that many other cities across the country now are mimicking and modeling after. He's won numerous research awards and teaching awards from both local organizations such as of course, the University of Texas. He's a native son of Texas, to national organizations like the American Heart Association. So any and all questions stroke related, go to Jim tonight. And Jim, thanks for being here.
Okay, well, thank you, David, for that introduction, and Frances for that great talk about things in general and letting me talk about the stroke issues. And I want to reemphasize, I was hoping that when we organized this, said, well, maybe COVID by that time will be dying out, but I can tell you from experience here in Houston, and those of you on the line from Houston know, things are surging, and this is not a disease that's going away. So it's going to continue to be relevant, and its effect on the brain is going to continue to be relevant. And please, I'm going to be focusing on stroke, and I want to make 4 main points, but when I'm done, please, we can, and I think I speak for Dr. Jensen also, just ask us any questions you want about COVID. We'll do our best to answer. So the first thing I want to make about the relationship of COVID and stroke is actually an indirect one. And yes, we'll talk more about how COVID can cause strokes, but the biggest impact on stroke is that what COVID is doing is it's scaring people away from coming to the emergency room and getting appropriate care for their strokes. So there's been about anywhere from 20 to 40% reduction in the percent of patients who are getting appropriate treatment for their stroke since the advent of COVID, because people are just not calling 911 because they're afraid to catch COVID when they go to the hospital, or that medics are too busy or whatever. And as you know, hopefully, treatment of stroke is very effective, very time sensitive. So if you don't call 911 in time, you're not going to get treated effectively. We see this all the time on our mobile stroke unit, where we respond and we find that patients have waited a day or two until they're totally paralyzed before they call for help, and that's taken away their chance of treatment. And that's true for all emergencies. It's also true for heart attack, trauma, and other conditions that need emergency treatment. So the first and most important message I want to get out is that COVID should not dissuade people from calling 911 if they have an emergency. As a matter of fact, you're less likely to catch COVID if you go to the hospital than you are if you go to a restaurant or to the grocery store. Because in the hospitals, everyone's masked up. We know how to take precautions. It's very rare for hospital personnel to catch COVID from within the hospital, and for patients to get COVID while they're in the hospital. In fact, when our medics and our medical personnel get COVID, it's almost always due to catching it outside of work and not at work itself. So I hope I've made that point clear. Now, as was pointed out by Frances, one of the things that happens with COVID, one of the important things we've learned, is that there's this cytokine storm of immune response, and this sets off a blood clotting cascade. And so that in all organ systems, including the brain, what we're finding is that the patients who get the sickest are the ones who also are developing blood clotting in their organs. They're getting blood clots in their lungs. So one of the reasons why it's so hard to get patients oxygenated when they're on lung machines, and you've heard about people who go into the ICU and we put them on ventilators, and these are the sickest COVID patients, and we still can't get them, can't get enough oxygen into their blood. And it's because that the blood vessels and the tiny blood vessels in their lungs are blocking off. And similarly in the kidneys, the patients are developing kidney failure because blood vessels in the kidneys are blocking off, and in the heart. But it also happens in the brain. What we found is we've done research, and by the way, all the 4 things I'm going to mention are subject to research. We're doing research in why patients are not coming to the hospital. It's an interesting behavioral thing. But we're also doing research in the blood clotting abnormalities. And what we found is that what's happening is the blood clots that are forming much more strongly. And they're not dissolving. And blood clotting is a dynamic process. Your body has its own natural blood dissolving compounds. In fact, we use these to treat patients with strokes. TPA, or the clot busting drug that we use for treating strokes, is actually the body's own chemical that's used to break down blood clots. What we found is that in patients with COVID, they don't break down their blood clots. They form clots, and they form them, and they form very hard and durable, and the body's unable to break them down. So there's a lot of research in this. In fact, almost everybody with COVID who comes into the hospital has signs of blood clotting. There's a blood test we can do called the D-dimer. If you do a D-dimer on every patient that comes in with COVID, they're elevated in almost all patients, indicating that there's some level of blood clotting, that's abnormal blood clotting that's occurring in virtually everybody with COVID. And when it happens in the brain, it causes very severe strokes. And it happens in patients who we don't expect to have strokes. So the last patient, it's 40 with this that we saw in our mobile stroke unit, a 40-year-old man who had no reason to have a stroke, came in with a very severe occlusion of his main artery in the left side of his brain, and developed, and despite the fact that he got all the treatments, including clot busting treatment and the catheter extraction of his clot, he continued to form clot for the reason I mentioned, and he eventually developed brain swelling, and he died of his stroke. So these are very bad strokes that patients get when they're on COVID, if they have COVID, and it's due to this excessive blood clotting. And so there's a lot of research going on. In fact, we've put in a grant to the federal government. We have a harebrained idea that maybe what we should be doing is when patients are first diagnosed with COVID, we should anticoagulate them and put them on blood thinners right then and there in order to head off the blood clotting problem, which seems to be one of the things that's producing stroke. So again, there's research on all of this, and it ties into other research in stroke. You know, as you probably know, blood thinners and anticoagulation are used in many patients at risk for stroke. For instance, patients with atrial fibrillation. So the same drug that we use for preventing stroke in patients with atrial fibrillation, maybe that would be useful in preventing strokes in COVID patients. So that's the second point I want to make, this blood clotting cascade. The third is, what I alluded to, is that strokes are occurring in young patients who shouldn't have it. Now, we've all heard that patients in nursing are disproportionately affected, and they definitely are. I can't remember the specific, but I think well over half the cases of COVID hospitalizations are the elderly patients and who have comorbidities. But we're also seeing strokes in young patients, particularly Blacks and Hispanics, who have no good reason otherwise to have a stroke. These are patients without risk factors, and we don't really understand what this is and why this is. Is it, certainly there are socioeconomic issues and disparities in healthcare that we've all read about in the paper these days. It's even more newsworthy than the COVID issue is all the issues in our communities now with racial disparities. And it occurs with COVID as well. We have a huge you have the incidence of hospitalization in blacks is 4 times as high as it is in whites. And we don't understand this. Is it all socioeconomics and health access? Dr. Jensen alluded to the fact that COVID attacks the angiotensin receptor in the lungs. Maybe there's a difference, and we know that blacks and Hispanics respond differently to antihypertensive drugs, different groups, depending upon probably some genetic issues that may have a relationship to their angiotensin receptors that may make them more susceptible to COVID. Anyway, this is areas of research that we don't understand that we need to do that may indicate why some people get these bad strokes and other complications of COVID and others don't. So as you can imagine, virtually every funding agency in the country is interested and looking for research in not just COVID, but why there's such disparities in age and race and in terms of its incidence. Finally, as was pointed out, the fourth point I want to make is that patients with COVID have sequelae, and it's not just the Parkinson's disease and the Guillain-Barré. When you're in the hospital on a ventilator or sick, it's appearing that patients are coming out of the hospital with a lot of behavioral and cognitive abnormalities. They're just not the same. Just like when somebody's had a closed head injury, they fall off their bicycle, or have a bad concussion, and they're not the same for months afterwards. They have memory impairment, personality change, and we're seeing the same thing with COVID. So again, a similarity of multiple diseases. Is COVID sort of a model for traumatic brain injury and for cognitive things that we see with aging? And so if we understand what it is that's triggering this with COVID, then maybe we can also understand how we may be able to treat brain injury from other things better. So that's another very important area of research. So with that, I think that pretty much concludes the 4 main points I want to make about stroke in COVID. It is a big problem, but it's related to a more generalized blood clotting abnormality that seems to really add to the morbidity of this disease. And if I can leave you with one message, please, for you, and tell your friends, if you have a problem, an emergency problem, please don't avoid going to the hospital just because COVID is around. So with that, David, I'll hand it back to you, and I'll be glad to answer any questions that come up. I don't see if there's any chat questions for me.
Yep, there are some chat questions. And Jim, thanks so much. And just to drive Jim's point home, this became very personal to me recently when a good friend of mine and colleague was recently found comatose by his wife when she arrived home. And she immediately brought him into hospital, and what had happened was he had a stroke. The blood clot that formed was in an artery called the basilar artery, which supplies the brainstem. And that's, as Jim will tell you, almost uniformly fatal unless that blood clot is dissolved or extracted. Fortunately, they were able to get him in, rushed him in, gave him some blood thinners, and extracted that clot. And he's now making a decent recovery, actually a very good recovery. But the point that Jim was trying to drive home, which is get in quickly. If he didn't get in, or if he wasn't taken in, he wouldn't be alive today. And he was young and healthy and had no reason, as Jim was alluding to, for having that stroke. He was young and otherwise healthy. So we see some questions coming in here, and maybe I'll throw this one out to either of you regarding worse outcomes for people of African American descent. Most are vitamin D deficient, which has been correlated with worse outcomes for all patients. Can you address that?
Yeah, I can start with that. And then this link with vitamin D is quite interesting. It's also interesting that vitamin D deficiency is highest in the winter because of the lack of sun. So that might actually be a problem with the upcoming winter. Vitamin D deficiency, there are some studies, but nothing really conclusive to the best of my knowledge, that are suggesting that vitamin D deficiency is in some way increasing vulnerability to COVID-19. And it's because vitamin D has interacts with that angiotensin to converting enzyme that we've talked about, this ACE2 receptor. It interacts with the receptor in a way that might make it more, make the attack of COVID actually happen more if you are deficient. It could be protective, in other words. Its effect on the receptor may be protective. Again, this is an area of research that is still being done, but right now it's at the epidemiological level that we can say it looks like there's trends that vitamin D deficiency increases risk of severity of COVID-19. But the science behind it is going to be related to the fact that the vitamin D does interact with the ACE receptor, which has been implicated in how the virus gets into our cells across our bodies. So it's very interesting, and I think that's we are a little worried about there was a paper in the Lancet recently, an opinion piece that suggested that, people were adamant of people correcting vitamin D deficiency as part of the way to manage this pandemic. Hardly a cure, but just a protective mechanism.
Yeah, thanks, Frances. There's another question here. This individual sensed that the therapeutic approach was driven by specific mechanisms targeting one system, one symptom. Is that the research and clinical focus? And what about approaches that could potentially target multiple systems at one time, like neuromodulation?
And I can try to take that, and then I'm handing it over to Jim. But I think, again, the fact that we know some of how this virus locks onto cells with this ACE2 receptor, and that is all over the body, that is kind of one mechanism. The other, though, is this more general hyper-inflammatory syndrome, this cytokine storm. And I think that we know a lot about the presence of the cytokine storm and the consequences in multiple organs. And so, again, being able to focus on those root causes, you would potentially get a therapeutic effect across multiple organs in the body, not just the brain. We are trying to look to see, there's a special form of autoimmune attack that only is in the brain. And remember that neuroscience has shown us that your brain's immune system is actually a little different from the rest of the body's immune system, and that there's something called the blood-brain barrier, which you get through, and we have trouble getting drugs into the brain because of the blood-brain barrier, which is there to protect the brain, to keep it in its own little environmental sphere, if you will. But it has its own immune system as well, which can be triggered to go awry in a very specific way. And remember when I mentioned this brain on fire, that most people most people know that term, that opened up a whole group of very specific immune attacks that only can happen in the brain because the targets are only in the brain. So the question is, of course, how much of it is very specific to the brain versus a byproduct of a more systemic, affect all organs attack?
Yeah, I think, until we have a vaccine or a preventive biologic, that's going to require a multi-pronged approach to the treatment of these patients, including an antiviral. But as Frances said, as this disease progresses, anti-immune drugs that attack both these cytokines that are produced, and there are many of them. There's interleukins, there's 1 and 6 and 10 and 12, and there's tumor necrosis factor. And so there's a whole family of cytokines and inflammatory mediators, for each of which we have biologics now that are used for other diseases like rheumatoid arthritis and inflammatory bowel disease. And so a lot of these drugs are being repurposed because, as Frances said, we know a lot about the immune system, the individual mediators, and we now have FDA-approved biologics that target them. So as this disease progresses and people are really sick and close to being on a ventilator, it's not so much about killing the virus anymore, or as much about killing the virus as it is about suppressing this immune storm. So I think it's going to be a multi-pronged approach until such time as I think we have a vaccine or a preventive biologic.
So David, what do you think of the Decadron data?
Yeah, I think the Decadron data is really interesting. I'm not surprised, Jim. This was used in very sick patients, not quite as sick as the remdesivir patients, but I think that's the only treatment thus far that has rigorous evidence or decent evidence showing that it actually reduces mortality. And I'm not surprised by that because it's a more general immune suppressant. It doesn't target any one, well, it targets multiple inflammatory mediators.
So just for the folks on the call, Decadron or Dexamethasone is a corticosteroid. We've been using it for years for brain swelling and for reducing inflammation in all parts of the nervous system. And a study was done in Great Britain suggesting that it reduces mortality by 1/3 in patients who have to go on the ventilator, which is a big difference. Now, I think that remains to be, I'm not sure it's been published yet. Has it been? Have those data?
I don't think so. I don't think so.
I don't think it's been published.
No.
So like many things, the press is, comes out before the actual data. But I think most of us think that it makes sense.
And just to let you know that in most intensive care units right now around the country, people get a cocktail of drugs when they come into the intensive care unit. So they're treated with blood thinners, they're treated with dexamethasone, they're treated with antivirals, they're treated with these biologics that I talked about. So they're getting the kitchen sink thrown at them because right now we're just trying to sort of attack this from multiple angles. Another question here, has anyone seen a pure meningitis due to COVID with no other symptoms?
I can say that yes, that has been reported. That was reported. I actually have the I have the article actually of Filatov et al. That there was meningoencephalitis, but definitely actual. The CSF, the cerebrospinal fluid, had lots of cells in it. The PCR showed SARS-CoV-2, COVID-19, and the patient was kind of stuporous with a very classical pattern of pain and stiff neck, and then it proceeded to become the person became stuporous. There's a couple of cases of that in the literature, and in one case, the person died of brain swelling and had lots of had all the hallmarks on their postmortem of a meningitis.
But I do think that
with a stain of SARS in the brain, by the way.
Yeah. But given the number of cases of COVID,
very rare
of direct invasion of the virus into the brain and into the central nervous system is unusual. It's not. It's unlike other illnesses which attack meningitis. Neisseria, which is the cause of meningitis, or herpes virus, for instance, which actually targets the brain. This virus doesn't seem to be what we call a neurotropic virus. One seeks out the brain environment. So that's what makes it such a difficult, but also interesting, because its effect on the brain is through these indirect mechanisms that we need to understand.
By and large, right.
Doesn't make it any less serious. It just means that we have to work harder to understand why it's happening.
There's another question here along the line, since we mentioned dexamethasone. Someone's asked if dexamethasone were administered early in the course of the disease rather than in the very sick, wouldn't it suppress the immune system such that their infection would worsen?
Good question. And that's going to be tested, I'm sure. Someone's going to go out there and put patients on dexamethasone early on at the first time of hospitalization or even before and see, because it needs to be done. You're absolutely right. It may make things worse at an early stage. But yeah. I think by the time patients get to the hospital, the ones who are going to get sick are getting sick really fast. And so I think it's like in those patients, it is almost too late to start to do preventative stuff when they arrive at the hospital door.
Mhm.
Yeah, it might be to identify the patients early on when they're first diagnosed. It's not enough just to do a COVID test. Maybe we should be doing blood clotting assays on the patients at that time, or immunoassays, or measuring cytokine activity at the time the diagnosis is first made, and see if we can identify the ones and predict the ones that are going to get into trouble. That would seem to me the logical way to approach this issue.
As well as their oxygen saturation, because there's some odd things going on with that, you know, you hear these stories of people who the day before they were having a barbecue, and then by 2 p.m. the next day, they're headed to the ICU being put on a ventilator, you know, that they just compensate over a matter of 12 or less, you know, 12 or about 12 hours. And, but what you learn is that there are also people that may have been having a real problem with oxygenation, but that it's been creeping when they were asymptomatic. They didn't know they were sick. And some of the some really interesting observations that you can be looking at somebody with an oxygen level that they should barely be alive, and they're talking to you. And it might be because it took a day or 2 or 3 for for this to slowly fill in their lungs and stop the transfer of oxygen through their lungs. But it was gradual enough that they kind of compensated at each stage. And there were initially some mistakes made by putting those people on the vent too soon. And then they can have kind of they may not have needed to be on the vent quite as soon as they were, and they have all sorts of secondary effects from the treatment. But the people that have these very low levels, there was one, they call them happy hypoxics, meaning hypoxia, lack of oxygen, happy. They're talking to you. And you normally would be, you know, the person would be at death's door normally if it had happened in another setting, like, you know, a sudden lung injury or the like. So there's a lot we don't understand. And it's a lot we don't understand of how the body is reacting. And these asymptomatic, I mean, I think a big question for everybody is, so wait a minute, what's asymptomatic? You know, how asymptomatic? And then this business about lack of smell, right? It's, you know, thought to be getting directly into them. So what is it going to do? Is it going to hang out there many years, or is it over? We don't know, you know. So it's
I think
there's
that's
a lot of
really
questions.
It's an excellent point, Frances. You know, if I had COVID-19 and I were at home and I was asymptomatic, and you offered me a thermometer or a pulse oximeter, you know, this thing I can put on my finger and it measures my blood oxygen, I'd take the pulse oximeter. Because,
absolutely.
Yeah, we've seen cases where people come in with a blood oxygen saturation in the 50, 60%. And as Frances said, they should not be breathing, they should not be alive. And then they precipitously decline and end up on a ventilator. And had that been detected earlier, they could have gone in and could have been oxygenated, which is what I think happened to the Prime Minister of the UK. And why he was in hospital. He was just being oxygenated because they saw his oxygen saturation continuing to dip. A lot more questions here. One really good question, which is on everybody's mind, is any sense of when we will have a vaccine be widely available to the public?
The end of the year. Only
End of the year?
so far, Tony Fauci's been right about most of the things he said. He's optimistic about the end of the year, and or cautiously optimistic.
And then we have to choose who gets it, who are the highest risk people.
Yeah.
It's amazing how much, well, in so many ways, it's amazing how much controversy has arisen over COVID, even with wearing masks and all the rest. But the people who are ordinarily not anti-vaxxers are very nervous about this vaccine. I don't know why, but probably because they're feeling that it's being rushed. But certainly it is being rushed. But I'm confident that any vaccine, I can't say that. I would definitely look at the studies before I take a vaccination, make sure that the studies were done right. But I'm pretty confident that after all that's happened with this disease and getting it under control, that any vaccination that's touted out is going to be looked at pretty carefully for safety. Now, it may not be effective, but I think it'll be safe.
Yeah. Then, of course, we have to look at not only who will take it, and whether they'll take it, but when they'll have the option of taking it. So obviously, it's going to require mass production and hundreds of millions, if not billions, of dosages. So when we actually have results of a clinical trial and a vaccine's been shown to be safe and effective is one thing. When we can actually get it is going to be another. So yeah, maybe, hopefully by the end of the year, but certainly I think by this time next year, we should have at least one vaccine. We've got over 490 now at last count in clinical development. So hopefully one of those will hit. Let's see, we've got some time left. I was told that the virus is mutating too much for there to be a vaccine. Any thoughts on that?
I think that is everybody's concerned about that. I mean, we don't have a vaccine for the common cold. Flu you have to get every year. So it is not unreasonable to think that this is not going to be a one and done situation for this, that there'll be some sort of permanent vaccine that will permanently, lifelong, keep us safe from the next versions of coronavirus. And I do think that we don't fully understand what immunity means. We're kind of not in great shape right now because a lot of the immune kits aren't as accurate as they could be, just like some of the earlier PCR and the antigen kits to say whether you actually have the virus in you. How they vary. Some are 50% wrong. Some are very, very good and with very few errors and what we call false positives or false negatives. But I think where the immunity is being studied, like how immune is immune and how long does it stay. There's a lot of kind of talk amongst the virologists that it may only be for months that you have the level of antibodies in your system, and then they drop. And are you still immune? They've done some work in animal models to show that it may fade. So there's just so much more to understand about it, I think. And we don't know whether maybe the vaccine's going to be more effective because it picks a more broad part of the viral, coat or some aspect of the viral protein, the virus that is shared no matter how mutated you get. So you're good. Again, these are all questions that are being asked.
Fortunately, the vast majority of the time when viruses mutate, they become less virulent. So it attenuates the virulence of the virus over time. And as Frances said, I think there's enough cross-reactivity, like people who are infected with SARS and MERS apparently have, there's some evidence that they have an immune response against COVID-19 just because of that, the sharing of that spike protein. There's enough similar about it that the antibodies look at it and think that it's COVID-19 even.
Yes, and I'll just, to interrupt, they're used for control. So when they're looking at people who have just had a COVID infection and they're looking at their antibody levels, they've used historical blood from 5-10 years ago as the control samples, and they're in those control samples, there's still like some percent, like 10% that have immunity to COVID-19, suggesting that there is cross-reactivity, that maybe COVID-19 didn't exist, but something very close to it did, that people were became immune to.
That's why I'm also kind of hopeful about the emergence of these biologics, these monoclonal antibodies that target the spike protein on these viruses, because they can be used both preventively and as a symptomatic treatment when you do contract the illness, almost like a Tamiflu, for example, except it's injected. So so I'm optimistic that, and several of those look promising right now. So it's not just vaccines; it's also
that might come before the vaccine, actually,
and
get into production faster.
Yeah, more. I think that's would be an incredible weapon if we were able to develop it, and that's important to realize. People are working on this. It would be like basically it's a antibody that you give that coats the virus, and it coats all of the spikes on it, so it doesn't really matter if it mutates. It'll basically inactivate the whole family of those viruses. Might keep us from getting cold too.
Well, I see that we're kind of running out of time, but maybe I'll end with this question, which seems, do you think we will truthfully one day go back to the way things were, or is that very far off? Each of you give an estimate of when, travel, big events, things like that.
Well, I can start off that I learned today that my institution has banned any business travel until December 31st, no matter what. I mean, they're not trying to control your travel, but your personal travel. But that's an interesting thing that many of the, many people in our industry, groups in our industry are saying no mass gatherings, no conventions, etc. So that's changing our life a lot. I think it's going to be a year from now that we're probably going to be being as free with our travel and being in public spaces and mass transit. I can't imagine it over the winter, given what I'm seeing with the way we're seeing these ups and downs throughout the country. And look, you're in Houston, I mean, you're in Texas, right? And what Houston is going through right now, it's going to happen to another city, keep happening.
So I agree that I read this one article, I think it was 517 epidemiologists were interviewed and asked when they would be willing to go to a meeting again. And I think the consensus was sometime next spring that they would be willing to go out and do things. Now, it all depends on what you consider normal. I think we're never going to look at things the way we did before. I mean, I think airplanes, it'd be crazy for them not to try to look at new technology to try to prevent mixing of air and viral spread in airplanes and screening people who are traveling. And I don't think but I think that in a year from now, I don't think we'll be wearing masks, let's put it that way. And I think we'll be able to go out to be in groups and things like that. But I don't think it's going to be much before next spring.
Yeah, I would agree with that. All of my meetings that I've had scheduled out through the rest of the year have been canceled. My travel has been suspended by my institution until December 31st. And as we start to prepare for meetings next April, next May, we're sort of thinking about putting together sort of hybrid meetings where part of it will be live and part of it will be virtual, because we really don't know by next spring, what the situation will be. But I'm hopeful that by this time next year, we'll have some of these biologics and perhaps even a vaccine or two available. And so we'll be able to start to move about the country and get back to life as we once knew it. Though I think we'll all be a bit more cautious about our behaviors. And I think airlines, for example, will be handing out packets with a mask in it and with hand sanitizer and things like that. And if we have a cold or we're flu-like, I think more people will start to wear a mask like they do in Asian countries, where if they're not feeling well, they'll put a mask on, particularly if they're amongst other people. So I think our behaviors will change as a result of this. I hope so.
Well, I mean, even the events like this, I mean, we've learned that actually meetings and things can be much more effective by doing it remotely. You can reach more people, you can do it conveniently. So I think of I know that there are a lot of people who've made money in the airlines and other industry, but we also waste a lot of fuel by all the air travel that's unnecessary. So I mean, I think that this is making us reevaluate a lot of aspects of our life that maybe we should change. Yeah. I never like to sit next to the guy next to me who had a cold.
Me neither. No. Me neither. And
that
by the way, I always
you'd be sick.
I always carried a mask in my briefcase, because if I got on a transatlantic flight, always for years, and I'm not Howard Hughes or anything, but if someone was hacking and coughing behind me or next to me, on a long flight, I felt a little safer with having a mask on. So with that, that's probably more information than you needed or wanted to know. But again, I want to be respectful of everybody's time. It's at the top of the hour, and I want to thank you all very much for a great evening and for spending some time with us. I hope you found the discussion helpful. And if there are any other questions that we haven't gotten to, or questions come up that you haven't thought about as you reflect on a conversation tonight, please send them to Lisa Dahlberg, and we'll be happy to answer those for you. So we're more than happy to be here and serve as a resource for you for any questions you have related to COVID-19 or COVID-19's effect on the brain. We've started a COVID-19 research fund at the American Brain Foundation. And, you know, we're focusing on trying to uncover and understand the effects of COVID-19 on the brain, determine whether there's a predilection for communities of color and why they seem to have a more severe outcome. And we're really interested in identifying, as we talked about, and tracking the long-term effects of COVID-19 and its treatment on the brain and nervous system. So we'll be working alongside our colleagues at the American Academy of Neurology to fund the best research in this area so that we can understand this quickly. There's a lot of work to do. We know a lot more than we did 5 months ago, but there's still a lot of work to do. So again, thank you very much for coming tonight, for joining us, and I hope to see you soon in the future.
Good night. Thank you.
All right. Good night.